Good morning, Dr. Phil here. Today we will be discussing on meningoencephalitis. Meningitis. Describe the most common signs and symptoms of acute meningitis syndrome. Classical symptoms include fever, neck stiffness, altered mental status, and headache. Up to 95% of patients will present with 2 out of 4 of these symptoms. Other symptoms and signs include focal neurologic deficits such as cranial nerve palsies, aphasia, hemiparesis, seizures, coma and rash. Onset hours to days. What is the pathophysiology of meningitis? Bacterial meningitis is defined as inflammation of the meninges, particularly the pia and arachnoid matter, associated with the invasion of bacteria into the subarachnoid space. Bacterial invasion into the CNS may be via high-grade bacteremia, leading to invasion of highly vascularized sites such as the choroid plexus and leptomeningeal blood vessels, direct access to the CNS in association with local infection, such as sinusitis or via dural defects. The pathogen gains entry via attachment on epithelial mucosal cells, endocytosis by dendritic cells, and direct vascular access. In the setting of bacterial meningitis, infection leads to cytokine production and influx of inflammatory cells. The blood-brain barrier may have changes in permeability, allowing for protein entry in addition to inflammatory cells and fluids. Vasculature dilates, but then becomes stenotic with infiltration of inflammatory cells. Vasculitis may lead to ischemia and/or infarction. There is increased glucose metabolism, and transport across the blood-brain barrier decreases. What is the distinction between acute versus chronic meningitis? Acute meningitis syndrome consists of fever, neck stiffness, and altered mental status with an onset of hours to days. Patients with acute bacterial meningitis have rapid progression of signs and symptoms. Chronic meningitis is defined as the presence of symptoms and abnormal CSF that persist for 4 weeks or more. The two syndromes have very distinct causes. What host factors are important to consider regarding the risk and causes of acute bacterial meningitis? General factors to consider includes age, immune deficiency, CNS instrumentation, possible exposures, lack of immunization, and expansion of non-vaccine serotypes. Specific risk factors for Streptococcus pneumonia, hyposplenism, alcoholism, HIV infection, chronic liver or kidney disease. For Listeria monocytogenes, age more than 60 years old, immunocompromised state, alcohol dependency, diabetes and malignancy. For Staph aureus infection, endocarditis. For viral meningitis, young adults, especially women aged 20 to 40. These factors should be considered and will influence empiric therapy. For age less than 1 month old, common pathogens include Strep A galactiae, E. coli, Listeria monocytogenes and Klebsiella. Empiric therapy, ampicillin and third-generation cephalosporin. For age 1 to 23 months old, common pathogens include Strep A galactiae, E. coli, Haemophilus influenzae, Streptococcus pneumoniae, and Neisseria meningitis. Empiric therapy, vancomycin and third-gen cephalosporin. Age 2 to 50 years old, common pathogens, strep pneumoniae and Neisseria meningitis. Empiric therapy, vancomycin and third-generation cephalosporin. Age more than 50 years old, common pathogen includes strep pneumoniae, Neisseria meningitis, Listeria monocytogenes, and aerobic gram-negative bacilli. Empiric therapy, vancomycin, third-gen cephalosporin, and ampicillin. For immunosuppressed patients, common pathogens include strep pneumonia, Neisseria meningitis, Listeria monocytogenes, aerobic gram-negative bacilli including nosocomial organisms. Empiric therapy, vancomycin with carbapenem or 4th-gen cephalosporin with ampicillin. Post-neurosurgery, common pathogens, Staph aureus including MRSA, coagulase-negative staphylococci, and aerobic gram-negative bacilli. Empiric therapy should include vancomycin, carbapenem or 4th-gen cephalosporin or ceftazidime. What are the most common causes of community-acquired acute bacterial meningitis in adults? This includes strep pneumonia, Neisseria meningitis, Listeria monocytogenes, Streptococcus agalactiae or pyogenes, Staphylococcus aureus, Haemophilus influenzae. Preferred antimicrobial depends on sensitivity testing for strep pneumonia, penicillin or ampicillin if sensitive, third generation cephalosporin and vancomycin if not sensitive to penicillin. Suggested duration of therapy 10 to 14 days. For Neisseria meningitis, penicillin or ampicillin if sensitive, third gen cephalosporin if not. Suggested duration of therapy 7 days. For Listeria monocytogenes, ampicillin or penicillin. Suggested duration more than 21 days. Strep agalactiae or pyogenes, preferred antimicrobial ampicillin or penicillin. Suggested duration 21 days. For MSSA, nafcillin or oxacillin. For MRSA, vancomycin. Suggested duration 14 days. For Haemophilus influenzae, if beta-lactamase negative, ampicillin. If beta-lactamase positive, third gen cephalosporin. Suggested duration 7 days. What is adequate empirical therapy while awaiting culture results? Empiric therapy should reflect suspected pathogens on the basis of host factors, as well as local antibiotic susceptibility patterns. Empiric therapy for suspected meningoencephalitis to be commenced within 1 hour. Cefotaxime 2 gram every 4 hours or ceftriaxone 2 gram every 12 hours, with or without vancomycin 10 to 20 mg per kg every 12 hours, if in an area with high levels of pneumococcal resistance to penicillin, with or without amoxicillin 2 grams 4 hourly, if age more than 60 years or other risk factors for Listeria infection is present, with acyclovir 10 mg per kg every 8 hours and dexamethasone 10 mg every 6 hours. In the event that a patient has undergone recent neurosurgical instrumentation and has risk factors for nosocomial infection, one should also include therapy directed at MRSA and gram-negative bacilli such as Pseudomonas. Risk factors that may additionally influence empirical therapy must be identified. Prompt and detailed history should be explored. Factors to explore includes exposures such as contaminated food consumption, travel history, and sick contacts, presence of immunosuppression, and risk factors for nosocomial pathogen infection, such as recent neurosurgical procedures, epidural injection, presence of foreign body within the CNS, and trauma. When and to whom should steroids be administered? Based on a Cochrane review in 2015 by Brower MC et al., which included data from 25 studies, both in adults and children, corticosteroids significantly reduced hearing loss, neurological sequelae, and reduced mortality in patients with pneumococcal meningitis, but not the overall group. Guidelines recommend that dexamethasone be started shortly before or with the first dose of antibiotics in all patients suspected of having bacterial meningitis. If not given within the first dose of antibiotics, steroids can be given up to 12 hours after antibiotics have been started. Treatment should be stopped if a pathogen other than strep pneumonia or Mycobacterium tuberculosis is isolated. Steroids should be continued for 4 days in pneumococcal meningitis. For TB meningitis, steroids should be given at high dose for 6 to 8 days, then tapered over 4 to 8 weeks. What are therapies with no benefit in meningitis? This includes therapeutic hypothermia, prophylactic anti-epileptics, hyperosmolar therapies, and ICP-based treatment. What are the contraindications to lumbar puncture? Based on NICE recommendations 2016, this includes signs suggesting raised ICP or reduced or fluctuating level of consciousness, relative bradycardia and hypertension, focal neurological signs, abnormal posture or posturing, unequal, dilated or poorly responsive pupils, papilloedema, abnormal doll's eye movement, shock, extensive or spreading purpura, after convulsions until stabilized, coagulation abnormalities, coagulation results outside normal range, platelet less than 100, or patient receiving anticoagulants, local superficial infection at puncture site, and compromised respiratory function. When would one consider imaging before lumbar puncture? Most patients do not require imaging before LP. CTH should occur before LP if the patient has any signs or symptoms that suggest raised ICP in patients with moderate to severe cognitive impairment and immunocompromise. Is there harm in awaiting CT and lumbar puncture results before initiating therapy? Yes, delay in initiating antimicrobial therapy has been associated with increased mortality. If imaging is needed before LP, obtain blood cultures, initiate antibiotic therapy and steroids, obtain CT head, and perform LP if safe. Regarding pre-treatment with antibiotics, CSF cultures may be affected by pre-treatment with antibiotics before LP, but CSF findings including cell counts, chemical analysis, and gram stain should remain helpful. What CSF studies are important? This includes opening pressure, appearance, protein, glucose, gram stain, CSF glucose to serum ratio, white cell count, and others. This table shows the typical CSF results for normal, bacterial, viral, and fungal or TB infection. For opening pressure, CmH2O, normal is 5 to 20. If bacterial infection, more than 30. For viral infection, normal or mildly increased. For fungal or TB infection, variable. Normal appearance is clear. Bacterial infection, turbid. Viral infection, clear. Fungal or TB infection, fibrin web. Protein in grams per liter, normal is 0.18 to 0.45. If bacterial infection, more than 1. Viral infection, less than 1. Fungal or TB infection, 0.1 to 0.5. Normal glucose in millimoles per liter is 2.5 to 3.5. Bacterial infection, less than 2.2. Viral infection, normal. Fungal or TB infection, 1.6 to 2.5. Gram stain is 60 to 90% positive in bacterial infection, but may be negative in viral infection. Acid-fast bacilli or cryptococcal stain may be positive in TB or fungal infection. CSF glucose to serum ratio, normal is 0.6. Bacterial infection, less than 0.4. Viral infection, more than 0.6. Fungal or TB infection, less than 0.4. Normal white cell, less than 3. Bacterial, more than 500. Viral, less than 1000. Fungal or TB infection, 100 to 500. A positive gram stain confirms bacterial meningitis. Sensitivity is between 50 and 99%, depending on the causative organism and prior antibiotic treatment. Cultures and sensitivity is the gold standard for diagnosis of bacterial meningitis. Culture data is important for speciation and antimicrobial sensitivities. Positivity rate depends on causative organism and prior antibiotic treatment. CSF glucose is low in acute bacterial meningitis, TB meningitis, and malignancy. A CSF lactate of greater than 4 millimoles per liter is 88% sensitive and 98% specific for the diagnosis of bacterial meningitis. A cutoff level of less than 2 millimoles per liter essentially rules out bacterial disease. PCR should be considered for meningococcal, pneumococcal, HSV1, HSV2, varicella zoster virus, and enterovirus. Multiplex PCR assays has enabled concurrent testing for an array of bacterial, viral, and fungal pathogens. Further CSF microbiological testing depends on immune status, geography, and travel history. This table lists investigations for all patients, immunocompromised patients, returning travelers, and to investigate for autoimmune encephalitis. Lumbar puncture should be performed within 1 hour for patients with suspected bacterial meningitis and within 6 hours for suspected encephalitis in patients in whom it is safe to do so. Other investigations to consider in immunocompromised patients apart from the above mentioned include CMV and EBV PCR, HHV PCR, JC virus PCR, HIV serology, toxoplasma serology, toxoplasma PCR, cryptococcal antigen, Aspergillus PCR, galactomannan, CSF and blood culture for listeria, CSF for syphilis, TB culture, and PCR. For returning traveler, consider investigations for cerebral malaria, flavivirus, Japanese encephalitis, dengue encephalitis, St. Louis encephalitis, West Nile encephalitis, tick-borne encephalitis, Toga virus, Eastern encephalitis, Western encephalitis, Venezuelan encephalitis, Rio viridae, Colorado tick fever, Rhabdoviridae, rabies, Chandipura virus, Henipa viridae, and Nipah virus, mostly via CSF PCR or serology. For autoimmune encephalitis, investigation for anti-NMDA receptor encephalitis is anti-NMDA receptor antibodies. For anti-VGKC complex encephalitis, investigation is anti-VGKC complex antibodies. For Bickerstaff encephalitis, investigation is anti-GQ1B antibodies. For paraneoplastic encephalitis, ANNA1 or anti-HU. For Hashimoto encephalitis, investigation is ANNA2 or anti-RI. For ADEM, investigations includes anti-MA1, anti-MA2, anti-amphiphicin, anti-thyroid peroxidase antibodies, and MOG antibodies. How does one correct for a suspected traumatic lumbar puncture? In the event of traumatic LP, one general guideline is subtraction of 1 WBC for every 500 to 1500 RBCs. More precise formulas are included here for completion. Subtract 1 mg per dl of protein for every 1000 CSF red blood cells. In the setting of documented bacterial meningitis, who gets post-exposure prophylaxis? The goal of post-exposure prophylaxis is to eradicate nasopharyngeal carriage. There are two pathogens for which one would consider post-exposure prophylaxis: Neisseria meningitis and Haemophilus influenzae. Prophylaxis for Neisseria meningitis. Indications includes extended period of contact more than 8 hours in close proximity within 3 feet, contact with oral secretions, household contacts, exposure 1 week before symptom onset until after 24 hours of effective antibiotic therapy. Post-exposure prophylaxis should occur despite history of vaccination. Suggested regimens: ciprofloxacin 500 mg orally times 1, or rivampin 10 mg per kg orally every 12 hours for 2 days, or ceftriaxone 250 mg IM times 1 in adults, or 125 mg IM times 1 in children. For Haemophilus influenzae, if there is a partially vaccinated child or child younger than 4 years of age, prophylaxis is suggested for all household contacts. Prophylaxis of daycare contacts can be considered if applicable. Suggested regimen: rivampin 20 mg per kg per day for 4 days, maximum dose 600 mg daily. What is aseptic meningitis? This is defined as a syndrome of meningeal symptoms accompanied by abnormal CSF, usually lymphocytic pleocytosis, in the setting of negative routine stains and cultures. Infectious causes include viral pathogens, Mycobacterium tuberculosis, Treponema pallidum, Borrelia burgdorferi, fungi, partially treated bacterial meningitis, and parameningeal focus. Non-infectious causes include medications, autoimmune or connective tissue disorders, and malignancy. What are important historical data to obtain to help determine possible etiologic viral pathogens? This includes time of year or season, exposure to animals, insects, travel history, water source, sick contact, environmental factors such as daycare, college, dorm, or military recruit, and sexual history, presence or absence of skin rash, genital lesions, and HIV status. What are the most common viral causes of meningitis? Commonest causes include enterovirus, Coxsackie virus, and echovirus. Other causes include flaviviruses, herpes viruses, varicella zoster virus, HIV, and respiratory viruses such as influenza and parainfluenza. Diagnosis is historically made with viral culture. However, PCR evaluation of CSF is now readily available. Viral load RNA quantification for acute HIV is necessary because antibody testing is usually negative during acute seroconversion. Next, we will be discussing on encephalitis. What is the pathophysiology of encephalitis? Encephalitis is defined as inflammation of the brain. For practical reasons, surrogate markers of brain inflammation are used, such as changes in CSF and imaging. Encephalitis can be infectious, post-infectious, or autoimmune. Mortality ranges from 4 to 36%. Risk of severe disability is nearly 50%. being highest in those with antibody-associated encephalitis followed by HSV infection. What symptoms and signs are commonly associated with encephalitis? Acute encephalitis usually occurs over a brief period of few days, as compared with chronic encephalitis, which can progress over weeks to months. Many patients will present with a prodromal illness with fever, myalgia, and anorexia, which corresponds to viremia. Neurologic manifestations that follow can range from headache, focal neurologic deficits, behavioral changes, to seizures and coma. Meningeal inflammation can also occur, resulting in symptoms suggestive of meningitis. GI and respiratory symptoms are frequent, irrespective of cause. Urinary symptoms are more frequent in TB infection. Features suggestive of autoimmune etiology includes subacute clinical presentation, extrapyramidal signs, intractable seizures, and hyponatremia. What are the most common causes of acute encephalitis? Despite often aggressive diagnostics, the cause of encephalitis in majority of patients remain unknown. Possible infectious causes includes viral, bacterial, parasitic, and fungal. Examples of viral infection include HSV, enterovirus, West Nile virus, VZV, SLE, influenza, HIV, Epstein-Barr, measles, rabies, and CMV. Examples of bacterial infection include Bartonella henselae, Listeria monocytogenes, Rickettsia, Anaplasma, and TB. Parasitic infections include Toxoplasma gondii and Naegleria fowleri. Examples of fungal infection include Histoplasma capsulatum, Cryptococcus neoformans, and Coccidioides immitis. Other infective causes include systemic sepsis, cerebral abscess, syphilis, and malaria. Examples of non-infective causes include autoimmune encephalitis, paraneoplastic encephalitis, CNS vasculitis, Behcet disease, primary or secondary cerebral tumor, cerebrovascular accident, ischemic or hemorrhagic, metabolic encephalopathies, such as hepatic or uremic. What should the diagnostic workup include? After careful history and physical examination, CSF studies as discussed in the previous section. Neuroimaging is recommended as soon as possible in suspected encephalitis. Purpose of neuroimaging includes to rule out space-occupying lesions, to identify radiologic features of raised ICP, to detect complications of CNS infection, such as cerebral edema, hydrocephalus, abscess, and encephalomalacia, and to identify potential source of infection, such as sinusitis, otitis media, skull base fracture, and recent intervention. MRI is superior to CT in diagnosing CNS infection due to increased sensitivity, and the characteristic pattern of focal changes helps determine the underlying pathology. If MRI cannot be performed, CT with contrast is the next preferred method. Other cultures apart from CSF culture includes blood cultures and cultures from other sites, guided by clinical examination findings. Serum PCR is recommended for certain infections such as meningococcus and pneumococcus. HIV tests should be sent in all patients suspected of CNS infection. Serum markers of inflammation such as CRP and procalcitonin is useful to monitor the progress of infection and inflammation. Serum lactate and plasma glucose will allow for interpretation of CSF results. EEG does not need to be requested routinely, but should be performed if seizure activity is suspected, and to look for encephalopathic changes. Various EEG patterns exist that may suggest underlying causes, such as autoimmune encephalitis and HSV encephalitis. Brain biopsy is reserved for cases in which initial evaluation has been unrevealing. Additional studies should be obtained in the context of the patient's epidemiologic risk, such as investigations for rickettsia, flavivirus, and rabies. Describe how you would manage a case of viral encephalitis. For patients presenting with clinical features suspicious of encephalitis, assess airway, breathing, circulation, and neurology, check glucose, involve critical care team if indicated, assess for clinical contraindication to immediate lumbar puncture, as described in the previous section. If there are no contraindications, proceed with lumbar puncture and send for investigations as described in the previous section. If there are clinical contraindications to lumbar puncture, proceed with urgent CT brain. If there is delay in imaging more than 6 hours, start IV acyclovir while results are pending. Assess for radiological contraindication to immediate lumbar puncture. If there is significant brain shift or swelling, tight basal cistons, or alternative diagnosis made, consider IV acyclovir and review every 24 hours for suitability for lumbar puncture and CSF studies. If CSF findings suggest encephalitis, proceed with IV acyclovir. If CSF studies does not suggest encephalitis, consider repeating LP after 24 to 48 hours if indicated. If HSV or VZV encephalitis is confirmed, assess whether the patient is immunosuppressed or age 3 months to 12 years old. If yes, provide 21 days of IV acyclovir. If no, provide 14 days of IV acyclovir, then repeat LP. If PCR is negative, stop acyclovir. If PCR is positive, continue 7 days of IV acyclovir and reassess CSF PCR. If alternative diagnosis is made based on imaging and investigations, involve neurology and infectious disease teams and treat accordingly. Additional investigations are listed here for completion. Empirical treatment should be initiated within 6 hours of clinical suspicion of encephalitis, ideally after CSF sampling and neuroimaging. This will usually be IV acyclovir, 10 mg per kg TDS. Dose should be renally adjusted. Acyclovir inhibits viral DNA synthesis and is relatively non-toxic. Acyclovir has good antiviral activity against HSV and VZV, the most common causes of viral encephalitis. It reduces mortality of HSV encephalitis from 70% to 20 to 30%. Oral valacyclovir can be considered as an alternative to acyclovir after 2 to 3 weeks. Immunosuppressed patients or those with a history of recent foreign travel should be discussed early with the medical microbiology team, as it may be prudent to empirically cover a broader range of pathogens. These patients should be isolated from the main ward and nursed with barrier precautions. Given the overlap of encephalitis and meningitis syndromes, in appropriate clinical contexts, empiric therapy for bacterial meningitis can be considered. Consider transferring the patient to a tertiary neurological unit, which allows access to regular neurological specialist review, MRI imaging, and EEG facilities. Various aspects of critical care management should be implemented. This includes assessment of airway, breathing, circulation, and neurology, and resuscitation as appropriate. A proportion of patients with infective encephalitis will deteriorate and need critical care admission, typically due to the following: reduced consciousness requiring airway protection, respiratory failure due to reduced consciousness, aspiration, atelectasis, and poliomyelitis-like paralysis, and seizures refractory to initial anticonvulsant management requiring deep sedation. Principles of management of critical care is to provide organ and physiological support as required, and management to prevent or limit secondary brain injury. Organ support may be via invasive or non-invasive mechanisms. For patients with reduced consciousness, they may need closer observation and nursing care, interventions to protect their airway, and respiratory support if ventilation or oxygenation is compromised, which may include sedation, intubation, and mechanical ventilation. Measures for neuroprotection aims to reduce secondary brain injury. This includes maintaining MAP more than 80 mmHg, maintaining cerebral perfusion pressure more than 60 mmHg, maintaining PaO2 more than 100 mmHg, normal capnia, normal thermia, normal glycemia, Hb at least 8 grams per dl, avoiding cerebral venous congestion with 30-degree head-up tilt and avoidance of endotracheal tube ties, avoidance of cerebral edema associated with hypoosmolality, monitoring and treatment of seizures. If ICP monitoring is employed, efforts should be made to keep it below 20 mmHg. Treatment options to reduce ICP includes sedation, paralysis, osmotherapy, and decompressive craniectomy. Seizures should be controlled with anticonvulsants. or if refractory, infusions of sedatives. Initial recommended drug is IV lorazepam, 2 mg every 1 to 2 minutes to a maximum cumulative dose of 0.1 mg per kg. There is no evidence to support the use of primary prophylaxis. EEG has a role in determining whether the sedated patient is having seizures. It is also helpful in the investigation of patients failing to wake from sedation and to look for encephalopathic changes. The usefulness of corticosteroids in the treatment of acute infective encephalitis is unclear. They may be beneficial in treatment of vasogenic edema and mass effect, considered in VZV encephalitis with vasculitis or HSV CNS infection. Optimal dose regimen is unknown. Continuing antiviral treatment. For immunocompetent adults with proven herpes simplex encephalitis, IV acyclovir should be continued for 14 days and a repeat LP performed at this time to confirm if CSF is negative for HSV by PCR. If CSF is still positive, acyclovir should continue with weekly PCR until negative. For immunocompromised or pediatric patients with HSE, they should be treated with IV acyclovir for at least 21 days, following which a CSF PCR for HSV should be sent. Long-term oral acyclovir should be considered until the patient's CD4 count is more than 200. Treatment for VZV is acyclovir at a higher dose of 10 to 15 mg per kg. Treatment with CMV encephalitis includes ganciclovir, foscarnet or cidofovir. Enteroviral infection of CNS is treated with pleconazole or IVIG. Treatment of rickettsia is doxycycline. Regarding infective encephalitis in children, herpes simplex virus is the most common pathogen. Vaccination history should be elicited, as measles infection can lead to encephalitis. General management principles are the same as those outlined for adult patients. Children with suspected encephalitis should have additional involvement of pediatricians, pediatric neuroradiologists, and when indicated, pediatric neurosurgeons. These are my references. Thank you.